right. Good morning, good afternoon, good evening, everyone. Sorry for the slight delay. We had some issues with the interpretation, but it should all be settled now. And I'm happy to see everyone joining. We already have 200 plus coming in, so really pleased to see so many people online today. My name is Rike Kierkegaard. I'm with this program specialist with the HIV section at UNICEF headquarters in New York. And I'm really honored to be introducing this virtual launch of our new technical brief on pediatric HIV case finding, looking beyond infant testing, which was developed by UNICEF, CDC, and ECPAF together with other partners to support Pillar 1 of the Global Alliance to End AIDS in Children by 2030. So before we get started with the webinar, I would like to review a few housekeeping rules. First of all, as mentioned, we're very fortunate to have live interpretation in French and Portuguese. So please do go to the interpretation symbol at the bottom of the screen and select your language. You can then choose to completely mute the original audio, or you can hear it at a lower volume if you want. If you have any technical issues, please do send us a message through the chat box and we will try to support as soon as possible. If you have any general comments, please also send them through the chat box, selecting all panelists and attendees so everyone can see your message. And if you have any questions for any of the speakers, please send them at any time using the Q&A box and not the chat box. The Q&A box is located at the bottom of the Zoom window in the middle, and you can also mention who your question is addressed to. We'll take the questions at the end, but the speakers and panelists can also start answering questions as we go along through the Q&A box. And for the French and Portuguese speakers that have joined us today, please feel free to send your questions through in your own language, and we will have them translated to English. And then a final note that the webinar is being recorded, and the recording and the PowerPoint will be made available online after the webinar on childrenandaids.org. So without further ado, let's get started. We will start with opening remarks from Emilia de Vera. She's from the Maternal and Child Health Branch at CDC in Atlanta. So over to you, Molly.
Yeah, hi, good morning, good afternoon, and good evening. Thank you all for joining this webinar in which we're launching our technical brief, which was a massive joint effort. And it's the first product of the Pillar 1 group for the Global Alliance Initiative. And I'm going to just go over briefly the agenda for today's session, which will have two parts. The first part is an introductory part, which will be started with Ruslan, who will go over the pediatric epidemic and then how we went about developing this brief, followed by Susan Hrabchak, who will talk to us about the content of the brief. What will you find in the brief? And then Martha Mukaminega, who will host us in fielding questions about the brief. And then Jessica Gross will lead a panel of very interesting folks, including community, Ministry of Health members, and representatives of WHO and PEPFAR. So we have a packed agenda today, and I'm very happy that you've all joined to launch this brief. And to kick off, I'm going to transfer the mic over to Ruslan. Thank you all.
Ruslan, you're muted.
Sorry. Good morning, everybody. So my name is Ruslan Maluta, and I'm pediatric HIV specialist working in UNICEF in New York. So it's my pleasure to be with you today. So I'll start my presentations from introducing the first slide, which is the state of the HIV epidemic among children. So, and And you can see so that it is in the end of 2022. So according to UNAIDS estimates, it was 1.5 million children living with HIV. Among them, we have 130,000 new infections, and during that year, 84,000 AIDS deaths were registered. When we look at the trends since the beginning of the epidemic, we can see the enormous progress which was made in decrease of the new infections among children, and AIDS deaths among children. And that progress was started largely when antiretroviral therapy became largely available. But this broad slide, so this graph doesn't show the differences what happened between the countries. And the next slide, which I want to introduce, will show the dynamics, between countries. So you can see here in the next slide. So what's happened actually from the beginning of the epidemic? So on the Y chart, it's a newly infected children with HIV, and on the X chart, it's adult prevalence, where the bubble size actually is a population size of the children living with HIV in the country. And you can see here, how the dynamic happens. So how dramatically drop actually the total number of children living with HIV, in different countries. This is example of Zambia, or Malawi, for example, the way they've done or South Africa, even more drama. So you see, not actually no drama, but the progress actually. So when we see the peak of new cases, which go on all the way to almost 70,000 per year, and drop to less than 5,000. With the next slide, this is a similar chart, but in this time, I am showing you the dynamics on the AIDS deaths among children. So in countries with different prevalence, high prevalence and low prevalence. And you can see here, we also observe the same patterns. So we can see that deaths increase, especially look at this dynamic in South Africa, how death rate increase among children, until antiretroviral therapy become available in 2007 broadly, and then how rapidly it got dropped, basically within just a couple of years. And the same pattern happened actually in Nigeria, which is it's much more low level epidemic, which is concentrated epidemic. With that, the next slide. I want to show the progress which was achieved in antiretroviral treatment. Because this is something which we're all proud of, and we see how since 2010 was a big scale up on antiretroviral treatment. Malawi went from just a little bit more than 20% in 2010, and went close to 80% in the year of 2017. So this is a huge progress. But at the same time, the progress not even in every country. We see, for example, like in South Africa, they also achieved a big progress, since 2010. But then at the level of the 60% coverage, sometimes it's become stagnated. And of course, all those things, stagnations in the progress resulted in less suppression of viral load among children. And we can see that very few actually countries, have viral load suppression rates more than 60% among children. Which is actually far beyond the targets set up by the UNAIDS. And when we look at the epidemic among children, first which come to our attention, it's about equality, equity, and the reality. And here, the knowledge of HIV status basically became one of the bottlenecks, of the access of children to antiretroviral treatment. And here, I want to demonstrate how different actually this knowledge of HIV status between children and adults. You can see, for example, that what's happening. So we can see how it's progressing, the knowledge getting better and better and better, basically. So among adults. So, and in many countries, especially high prevalence country, we see today, these days, so the knowledge is among adults is close to 90%. So, but when we look at the children, so very few countries have knowledge so about HIV status more than 60%. Most of them are less than 80%. So, and especially in countries where the low prevalence, for example, like Nigeria, we see that despite the knowledge of HIV status among adults come close to 100%, children knowledge of HIV status is stagnated at the level of the less than 40%. So we had a meeting, so in January 2023, so hosted by UNICEF, CDC, ACPOF, so and we invited all key implementing partners, so to discuss about so what could be done so to accelerate the HIV case finding among children. So and we come the proposal so that we need to develop a technical brief which will help to operationalize existing WHO guidelines so on HIV testing among children, so and help countries to use them so to accelerate the pace of case findings. So it went through many revisions this draft, so the whole previous year we worked hard, so and so final document was produced this year, so and it been approved, cleared so by all agencies, and that's a document which we would like so to launch today. So those in the list are the agencies, you know, and organizations which contribute to the development of the tool. And with that, I would like to thank all of you. So and hand over so to the next speaker, Susan Harpchak from CDC. Susan, floor to you.
Thank you, Ruslan. So today we just want to highlight a few key components in the technical brief, but we'll not be going into a detailed overview. So the brief begins with overall goals and objectives of the brief. The objectives are to describe the current challenges to scaling up HIV testing among children less than 15 years, and to provide a set of priority actions and context-specific strategies to accelerate HIV case identification among children. The goal of this brief is to address the first pillar of the Global Alliance through a focus on accelerating case finding and treating undiagnosed children, with the aim to provide strategic technical and implementation guidance to countries for interventions beyond infant testing. So why is this brief needed? As Ruslan mentioned, there's data from Eastern and Southern Africa shown here on the top right, and Western and Central Africa on the bottom right, which both demonstrate persistent inequities in the treatment coverage for children living with HIV. In both figures, the light blue represents ART coverage in children, and it trails behind the darker blue bar for adults. And as pediatric case finding is the gateway to effective care and treatment, this brief can help countries close these gaps. The next section of the brief highlights 5 key challenges to HIV testing and case finding among children. These include disparities in progress towards HIV case finding between children and adults and between regions, with inadequate testing volumes to reach targets. Globally, most new vertical HIV infections among children are diagnosed late, beyond 2 years of age. Data on the status of prevention of vertical transmission and the pediatric HIV epidemic by age group is not well utilized to target the right case-finding strategies. Stigma and misconceptions persist as major drivers of poor HIV testing uptake, and there are gaps in systematic approaches to reducing structural barriers to testing access for children. And HIV testing for children has not received adequate resources to identify children not yet on treatment. To help countries plan for addressing these challenges, the brief then highlights an action plan framework for countries to outline a process and identify priorities to improve HIV testing and case finding in children. The cycle begins with convening national partners to plan together, utilizing local data to inform gaps and identify priority actions for their context. It's important to highlight that case-finding approaches may differ by context, prevalence, and geography. As these priorities are implemented, it's also important to ensure M&E systems allow for tracking progress. And quality improvement approaches can be used to have a continued feedback loop to continue monitoring data and revising priorities to achieve impact and reach goals. The brief proposes 10 priority actions for consideration by countries to formulate a comprehensive response to accelerate pediatric case finding. These priority actions can be discussed during stakeholder meetings to develop country-specific plans that are data-informed and context-specific. The brief has detailed considerations for each priority action, but today we'll just mention the 10 actions. So the first is setting targets for program scale-up. The second, allocating adequate funding and resources for country plans. The third, develop a catch-up strategy to identify undiagnosed CLHIV. 4, develop a maintenance strategy for sustainability. 5, use epidemic context and data from programs to define strategies. 6, expand research for the use of assisted HIV self-testing among children. 7, address environmental determinants of health, stigma, discrimination, gender-based violence, and barriers. 8, launch community-led demand creation strategies and monitoring. 9, improve data collection and use to inform HIV testing programs. And 10, identify strategies to find and link adolescents living with HIV to integrated health services. We will do a little bit of a deeper dive into priority action 5, which is around using the epidemic context and data from programs to define strategies. This section has subsections for service entry points listed on the left of the slide, and also has a decision-making framework on the right that looks at HIV prevalence and pediatric ART coverage to help countries identify how to tailor some of these testing strategies at different entry points based on their EPI data. The brief ends with some country-specific data from UNAIDS estimates for the 12 Global Alliance countries as one source of data to start some of the country-specific conversations. Each country has 5 figures that visualize estimated CLHIV by 5-year age bands, knowledge of HIV status by children and adults, AIDS-related deaths by finer age band, trends in immunization coverage to identify opportunities for integration with MCH platforms, and trends in PMTCT and EID coverage. Additional country-specific data can supplement these visuals to identify country-specific progress and gaps to adapt the priority actions to their country context. So I'll now turn it over to Martha for questions and answers. Thank you.
Thank you very much. Again, thank you, colleagues from all over the world for joining today's webinar. This is time for questions. Do you have, and maybe before going to questions, allow me to introduce myself. I'm Martha Mukaminega. I'm the Associate Director for Pediatric and Adolescent at Elizabeth Glaser Pediatric AIDS Foundation. So we have heard from our 2 first presenters, and I'm quite sure you might have questions. I'm looking at the box for question and answer. I think responses can go there, but is there anyone who would like to raise the hand and ask question? Anyone? So while you are thinking of Shafiq, I see you have raised your hand. Go ahead.
Martha, thank you very much indeed. I actually raised my hand on behalf of Stuart Keane because he posted a message into the Q&A that I think is an important question for the panelists to try and answer. So back to you, Martha, but suggest that you ask Stuart Keane to speak.
Thank you, Shafiq. The question has just been posted. So, Stuart Keane, would you mind just opening your line and speak out? Go ahead. Hello? I'm not sure if you hear me.
No, I think because Stuart is not a panelist, he cannot ask the question. So
No, we can allow him to
So,
talk,
let
but I
me-
can't
let
find
me-
him in the.
Sorry?
We can invite him to talk. I just can't find him in the
Yeah,
list
that
of
was
attendees.
my request. If you can allow him to, if you can unmute the line and then allow him to speak. I can see he has raised his hand.
There we go.
Fantastic. So go ahead and ask your question. The line is again muted.
Hi, can you hear me now?
Yes, we
Yes.
can. Go ahead.
Yeah, no, great. Well, thanks very much, Shafiq, for spotting my question. It's about HIV self-testing, which over the years, I know there's been different views on the role of HIV self-testing, and depending on the age of the children. And I saw mention made or heard someone mention it, and I just wondered what role you're seeing and for what age group you're seeing that. Yeah, just within the brief. That would be very helpful to know that. Thank you.
So any panelist who would respond to that question? Susan, do you want to go first?
Sure, I'm happy to start and look forward to others adding. So this brief is advocating for expanding research for the use of assisted HIV self-testing among children 2 to 14 years. We have some preliminary data from several operational research and programmatic implementation of use of assisted HIV self-testing among this age group that has a lot of promising information. However, in discussions with WHO, there is a need for additional evidence to make a recommendation to further promote this approach and include it in their guidance. And so this brief is advocating for countries to expand research looking both at social harm, acceptability, feasibility, and other elements of implementation to add to the growing evidence base in this area. I look to any other panelist to add to this.
Yeah, that's great. No, thank you, Susan. As Susan mentioned, the brief really advocates for expanded research around assisted HIV self-testing in children. And we know that we're 40 years into this epidemic. And, we saw the number of AIDS-related deaths in children just in 2022. And so, we're really looking for practical ways to make testing easier for parents. And, similarly in COVID, we didn't do RCTs to see if we could pass out COVID tests to parents at pharmacies. But, we'd made them available so they could screen their own children. And so this is the type of operational research that we're promoting. And, PEPFAR is supportive of the use of assisted HIV-ST in children programmatically. And we're, very delighted that WHO moved from a stance of against to a neutral stance that allows ministries of health to kind of evaluate their own epidemic and setting and their own testing strategies and see where something like assisted HIV-ST may fit in their program, again, along with many other evidence-based strategies. So thanks for your question, Stuart.
Thank you, Jessica. Any other addition to that question? Thank you. There is a question asking if the brief will be translated in Portuguese. Any panelist has an answer?
I can handle that, maybe, Martha. We have actually not discussed translations of the document, but that's an oversight, not an intentional desire to not translate. We certainly will be considering translating these documents into French, Portuguese, and Spanish. But I think please look out for that soon. We will try to make that available to you as well.
Thank you, Shafiq. There is another question. Should we take into consideration the prevalence of HIV in the countries where we want to roll out the HIV self-testing 0 to 14? I think the panelists have touched on that one, unless there is a specific addition related to the age group as it is mentioned. Anyone to say a word on that?
Sure, Martha, maybe one thing I'll say is in the settings, both programmatic and study settings, where countries have implemented assisted HIV/ST in children, it's been very targeted. So for example, linked to index testing programs where the parents are living with HIV and their children have an unknown HIV status. So they're higher risk children. So essentially trying to make it easier so that they don't have to transport the children back to the facilities, or, even in settings like they've rolled it out in Nigeria, which is a low prevalence country. They did mostly assisted HIV/ST that was facility based, but had really good, strong results presented at ICASA. And then in Ethiopia, which has had a lot more conflict recently, and so much more harder for families to move about, and that implementation was supported by ICAP. And so again, it tends to be more targeted to date in the settings where we've seen it. Thanks.
Thank you, Jessica. So Nandita, you wanted to add something related, Nandita, you want to add something
Sure.
related to that question? Go ahead.
Thanks so much, Martha, and thanks for the question. I wanted to point out that with the HIV self-tests, it's important to look at what age they're validated to, because not all of them can be used down to, most of them can be used from 2 years onwards, but below that, we really rely on PCR testing, DNA PCR, in particular, to diagnose infants who are under the age of 18 months or about 2 years. So I just wanted to flag that for anyone, just to make sure that we all understand what age groups the self-test can be used in.
Thank you. Another question. People are asking for more rigorous HIV estimates to be sure that the number of children living with HIV are close to the reality. Can the low coverage could due to the overestimation? So any response?
Yeah, maybe I can respond to that. So, yeah, about 2 years ago, so there's a publication Lancet actually, which is compared to the HIV estimates among children, so which is produced by UNAIDS and compares them as a fear estimates. And actually, what was found, so that the numbers were pretty similar. So so there is no reason for us not to trust the estimations we have today. Of course, so the studies will continue, the tools will become more fine-tuned. So, but what we have now estimates, so we can rely on them largely, and but what we found actually, so what we see, because the other question was about that it's hard to find children actually, so living with HIV, harder than adults, and that's true. So because it takes more effort, so more resources, to allocate, to test children. So, and that's exactly in my presentation. I showed the slide about equity, so that we need to bring more efforts, more resources, to diagnose the HIV among children. Over.
Thank you, Ruslan.
Martha?
Another question. Do you want to add something, Maury?
Yeah, I mean, I just want to do a time check with us. I think there are two other questions, and maybe after that we need to move on to the next session. But
You're
thank
right.
you.
You're right. Thank you. So the following question, does the technical brief stratify case finding strategies by age band? For example, are there specific strategies for 10 to 14 years old versus young children? Who want to go for to respond to that question?
Martha,
Yes,
I can
Nandita?
just add a
Oh, you know what? I'll just say this really briefly. I think when it comes to stratifying or thinking about different case finding strategies, it is important to think about different age bands, because we know the situation will be different for younger children who are very reliant on their caregivers and will need to take the caregivers and the families into account. Whereas in older or adolescent populations, there may be some differences. And so I do think we have to adapt some of our strategies and think about the age groups that we are targeting in particular. And that's not to say that we focus on one age group over another, but that it's making sure that we have age appropriate strategies across the pediatric population.
Thank you. Again, I'm looking at the time. This question will be the last one. And I can see we still have a number of questions. And the organizing team will see how those questions can be answered, not during today's session, but certainly answers will be provided. So the last question is about anything to update us regarding the pediatric risk screening tool used at OPD and inpatient level for universal testing. Any update? Yes, Jessica?
Sure. Thanks for the question on risk screening. I do think this is an area where population-specific guidance is really important, because risk screening in children has been much more studied, and we have many more validated tools compared to adults. You know, with adults, we really recommend that they use HIV-ST if they're going to use a screener versus like a question-based tool. But for children, you know, again, the recommendation is if the child is in a high prevalence country and they have an unknown HIV status and they're presenting to outpatient, that child would be offered HIV testing. That's the gold standard, right? But we know that some countries have resource constraints, health workforce constraints, and other constraints. And so risk screening is a way that we can be sure that if there are limited commodities and tests, that they're directed towards children with the highest risk. And so again, the gold standard is that, you know, all children with an unknown status be offered an HIV test. And then, you know, once they have a known status, there's no need for retesting unless there's a new exposure. But risk screening really can help us focus those resources. But again, the recommendation is that the tools be validated, you know, for the setting in which they're going to be used. So we know a tool validated in one country, but used in another country will have a different sensitivity. And so, you know, again, there's a lot of literature that's been published to date. And so we have a better idea of how these different screening items perform.
Thank you, Jessica. Again, we will try to respond to the questions in the Q&A box. Thank you again for all those questions. They're all important, and they show the interest you have in this technical brief. We will continue to respond to those questions. And yeah, but for now, let us go to the next phase of the webinar. And Jessica, to you.
Wonderful.
Thank you.
Thanks so much, Martha. And thank you for the overview of the brief. I'm Jessica Gross. I'm with the Bureau of Global Health Security and Diplomacy, or GHSD, PEPFAR, where I co-lead HIV testing services. And I'm delighted to be with you all today and with our panelists. We have several panelists today that include a mother of a child living with HIV, program managers from Ministries of Health, as well as colleagues from the funding side of things at PEPFAR, and also from WHO. And so we'll start the panel with a question for the mother on our panel from Uganda. And then we'll go kind of panelist by panelist and have a discussion. And so we have with us today Jogabiwe Hajara, and we just wanted to say welcome and thank you for taking the time to be on this panel today. There are nearly 300 colleagues on this call, and they're all very dedicated to increasing access to HIV testing for children and making it easier for their families. And so, you know, as a parent, it can be difficult to get your child tested for HIV. And we're curious if you would be able to tell us about your experience in getting your child tested and how old your child was when they were diagnosed.
Thank you. Before us, we have Mr. Mudashir and his wife, Chogabigwe Hajara, parents of one of the children that was identified as positive later. Both of them are negative, and Hajara prefers that the dad who was key in getting the child to the hospital for testing and who has been accompanying them for treatment and for all the psychosocial support sessions speaks to us this evening. My name is Brian and I work for Elizabeth Glazer Paediatric AIDS Foundation here in Uganda. Thank you. So Mr. Mudashir will talk to us as I interpret for him. Thank you. Sebo twakwakira bali kubuuza ngu otugambire ni aho wamanyire ngu omwana wawe Akram wana akawuka sirimu nekyakwalize kumukyebera niki kugira ngu n'abandi begereho. So I'm trying to give a preamble to him on to rephrase your questions on what he should talk to us this evening. Thank you.
Kabanjira akuvisitinga omwana wanje Akram.
He had gone to his son's visitation day at school.
Yasanga ine oburundu mukyakwawa.
And he realized his son had a skin rash.
Kunaize kumuya ishomero rwanje ngo ashukuru nansi naza kumuhereza omubazi yamusige waterere.
So he suggested to take the child away from school for treatment, but they said this is a minor rash and the school matron will handle it. But then 4 days later, they called him on phone that the situation had got severe and he needed to pick the son. That's when he picked the son from school and brought him to Komboni Hospital here in southwestern Uganda.
Kana mresire kuna mchizo wa doctor yangira ati igini kisipi igiro kuyamrebiri.
So when he got the child to the hospital, immediately the health worker said that was happy sister.
And then banyuma bamperiza bantwara wabashaha abandi aba basize kunyamba kunyereka kugira ngo umwana wanje abiriki.
But so when he was told it's happy sister, he was afraid because they know happy sister is associated with HIV and none of him between him and the wife was HIV positive. So that's when they took him to the ART clinic to initiate an HIV test.
ebwanyuma kutwashyikireyo teniikiriza ne bangambire nasharamu nagira nti bankebere na n'omwana wanje.
So when they told him after going through counseling and letting him know of his son's results, he couldn't believe it. And so he also suggested an HIV test for him, for his own self. And the wife's, which indeed came out negative, and the son's was still positive.
By that time akaine myaka 9.
And he says by that time the son was 9 years old. Yeah, so he's wondering if there are any questions or if that answers most of the discussions that we needed to hear from the couple.
Yeah, no, thank you for sharing your experience about testing your son. And, you know, I think we're also curious to hear if there's other types of support that as parents you felt would have been useful for you in the process of testing your child.
Bali kubuuza ngu nk'abazaire baratwara n'ogwo mwana obumuleeta kumukyebeza hiine nk'obuyambi omwabire mukwoyenzire obumutabwine
Bwanyuma tutakariisire mwana.
muri kumuleeta kumukyebera n'okumukyebera. He says no. He says the facility team at Komboni Hospital was extremely supportive, took them through thorough counseling before the results, and they felt they got enough support.
Thanks again for sharing your journey and your experience. You know, I think the individuals on this call work very hard every day to try to make these services, you know, more accessible and more focused on families and their actual, you know, journey to testing, so that when they get there, they do receive the support they need. So thanks again for taking the time to join this panel and to share your experience.
Webale munonga mali kubebaza kwikiriza kwija kuganira nabo kuba experience y'omwana wanyu.
Nabwo bebale wakira.
He says they are also extremely grateful for people like you that take the time to provide care for the children, but also recommends that if at all health workers would do a thorough screening for all illnesses for any child that comes to the hospital or facility, regardless of what the signs are, that would be helpful in identifying cases for people like them who do not have a personal interface with HIV.
Yeah, thanks. And you raised such a good point. You know, someone asked earlier about risk screening tools for children, and many of the validated tools have a screening item in there on recurrent skin problems. You know, again, trying to help providers identify who may be at higher risk and who to screen in for HIV testing. So at this point, we're going to transition over to one of our colleagues from the Ministry of Health. We have Dr. Caroline Wangi with us from the National AIDS and STIs Control Program, or NASCOP, in Kenya. Dr. Caroline, thank you so much for joining us today.
Thank you. Good morning, good afternoon, and good evening.
So Kenya is currently one of the most advanced countries in the Global Alliance in terms of progress towards case finding among children, with almost 85% of children being diagnosed as of 2022. And so we're curious what strategies and approaches the Kenyan government is planning to use to reach the remaining 10% of undiagnosed children living with HIV.
Okay, thank you for your question. And we have the highest level of commitment as a country from our Cabinet Secretary for Health, and indeed our President, that we must end AIDS in children in Kenya by 2027. And this will entail actually increased case finding amongst our pediatric population. So based on this commitment, the program undertook a rapid results initiative last year, over 3 months between September, October, November, all the way to December. And the target for this was actually identifying the missed opportunities, both in testing for our antenatal clinic that's identifying positive. We appreciate that if we are to diagnose children living with HIV, we actually have to diagnose the mother in most cases. Of course, we've had the scenario that has been presented. And so we embarked on that and selected throughout the country some select facilities and embarked on it and increased case finding. And then with the children that have been identified positive, actually improving the care and ensuring that quality of care for these children, those who are identifying those who are not virally suppressed, and ensuring that we were discussing these cases. So we've learned a lot of lessons from this exercise, but more importantly, in our devolved system of government, having the national level being responsible for development of policies and guidelines, but really the implementation of all these activities has to be done at the subnational level or the county level. So we've had increased ownership, like the counties, we sit down with them and identify, look at their data, we have ownership, and we have them coming up with action plans. So one important ask for us was that this is a sustained initiative, that we're ensuring that we are screening pregnant mothers and keeping track even during postnatal period. Our situation, we have found that we have quite a high number of cases of transmission occurring during breastfeeding. So what are the strategies that we can have in this? So we've started and we are having discussions about having enhanced, and it has come out also today, at all service delivery points. We are seeing these children, they're coming into contact with the healthcare system when they're coming for their well baby immunization clinics, when they're coming for outpatient visits when they're sick. So, and it's come out that even despite having, we can advocate for the HIV self-testing for age appropriate, but also that I liked the question of, are we able to identify the children at risk so that we test them? But more so, having the healthcare workers ensuring that they know the status of children who come into contact with the healthcare system. So that's one strategy. We want to work with the healthcare workers in the maternal and newborn and child health clinic to ensure that we are having this, the status of children is known so that we can increase our case finding. Also, we've also introduced the unique patient identifier for testing, for treatment, for PMTCT. So we're hoping that we'll be able to longitudinally track all the way from antenatal clinic and being able to tell a story as to, if I tested a mother, she turned negative, we have the identifier. So if this client comes again and we test and find they're positive, because of this unique patient identifier, we're able to go back and see what were some of the gaps that would have occurred. So even for children, so it's something we're scaling up. We've had quite a number of discussions within the program and with our stakeholders to ensure that we're able to longitudinally track and link, and this will go a long way in helping us also enhance identification of these children.
Yeah, thanks for that, Dr. Mwangi. And, in the brief, it mentions that, around 86% of children living with HIV that were identified after 2 years of age. So not dissimilar to the family that we heard from at the beginning of the panel. And so, we're also curious how Kenya's looking at age-based strategies for testing children of different ages.
Okay, a lot has been, some of the strategies we're talking about have been mentioned, like the HIV self-test strategy. And for us, we are bound by, of course, our various legal legal frameworks that discuss about testing of children, consent. So using that, because as a country, every country has its own unique legal mechanisms and legal frameworks for conducting that. So just using that, saying how we can advocate based on this and keeping within our guidance as a country to see when can we introduce self-testing. For the other the other age cohorts, I think having the caregiver, actually, I think it all has it all boils down to how are we involving the caregiver in testing, because for a certain age group, and even if we were to have HIV self-testing, we need the caregiver involved. So for us, even looking beyond this and saying how are we raising awareness in the community, because I think that one key partnership we need to have as a program is the community involvement, having the messaging and the information out there that, listen, yes, based on your child's age, we need to have this testing done, and either at a facility or empowering the caregiver to have it. Because one comment was that we're not trained, maybe we're not sensitizing or training them enough. And as a country, we know because of our prevalence, the recommendation of the 3-test algorithm, we're in the process of the country as adopting it and seeing how this, based on the piloting that we did, it's an algorithm that is best suited for the prevalence of the community. But now seeing how we're going to roll this out, and especially taking into account the testing of the children based on their age. And of course, with this, having the revised testing strategy so that we can be able to accommodate this. So the problem of having, we also see it as a country where we are finding very late cases of diagnosis, some as old as 10 or 11 years presenting with advanced HIV disease. So we have to look for innovative ways to reach this population of children, and some are even being identified as adolescents.
Yeah, no, thanks for flagging that, Dr. Mwangi, to like that late diagnosis. And we're always thinking about what are ways that we really can bring down the age at diagnosis. And there was a really interesting study that came out of Kenya that EGPATH did, Judith Coase and colleagues, and it was focused on adolescent testing. And what was so interesting is that it wasn't hyper innovative, right? What they were doing is they looked at the pre-intervention period and then the post, and in the post, all the adolescents that came in 10 to 19 presenting to the clinic for all kinds of different things, right? But they just looked to see, did they have a known HIV status, or had they been tested in the last year? And if not, they tested them. And they diagnosed 2.7 times more adolescents in the same 3-month window during the post period. And so sometimes it's a good reminder that, we may not need to be hyper innovative, but just kind of really focusing on like, what is our coverage like at places where the kids are, already presenting kind of day in and day out. So thank you so much for sharing, about Kenya's strategy and experience and looking at how to identify children across the age span. Now we're going to turn to Dr. Alice Kachagi from the Ministry of Health in Cameroon. Dr. Alice, thank you for joining us today. So Cameroon is a low prevalence country where the first 95 also lags compared to that of adults. So in Cameroon, about 39% of children living with HIV are aware of their HIV status, compared to about 96% of adults. And so we're curious to hear how Cameroon is working to expand coverage for pediatric index testing. In other words, ensuring all children with an unknown HIV status, of people living with HIV that are in our care and treatment programs, that these children are offered testing services. So Dr. Alice, over to you. And it looks like you may be on mute. There you go. Yeah, we can hear you.
Okay, are you talking to me from Cameroon or Kenya?
Yeah, if you're able to share Cameroon's experience, especially around index testing for children, or testing offered to the children of people living with HIV, we would love to hear more about Cameroon's experience.
Okay, good morning, and thank you for giving me this opportunity on behalf of the Ministry of Public Health in Cameroon. So I'll give some information concerning those questions that were asking. So maybe for introduce, I would say compared to Tanzania, Cameroon is a low prevalence country where the first 95 for children also lack compared with adults. So the HIV prevalence in Cameroon is 2.7%. And according to our information data, 26,886 children less than 15 years old living with HIV. And also, we would like to remind that 39% children less than 15 years old versus 96% for adults in 2022. So pediatric HIV care remain a priority for the Cameroonian government, and many interventions and priority are implemented to ensure that all children of people living with HIV in care and treatment with an unknown HIV status are offered testing. So these are some strategies that we implemented in Cameroon. The first strategy is to make sure that we make testing at all entry points in the health facility of children, at the vaccination, nutrition, consultation, tubing unit. And the second one that we implement is the family testing. So we do some outreach, and then according to the family, we see how to test some infant, maybe that were exposed and did not benefit for the PCR. The other strategy that we implement in Cameroon is we have a program called the OVC program by clinic and community collaboration. So for linkage to HIV testing service of children of people living with HIV and their siblings. And presently, as I'm presented like this, we are implementing a new approach in Cameroon entitled the pediatric search. What is the pediatric search? So compared to the routine services that we used to offer to infants in the health facility, so the pediatric search is an approach that emphasizes at the level of the community. It means we'll not stay in the health facility, but according to the land listing of children that we'll have in the health facility, so we'll see how to seek for those children in the community. So we need to work with community-based organization, and they are the one who will go and seek for those children in their community. So we have launched that approach in Cameroon last week, and this approach will be available within the 10 regions in Cameroon in all our districts. And at the beginning of this presentation, somebody asked a question to know whether the number of infants, to know whether that number was not overestimated. And in Cameroon, for us, I think after implementing this approach and get their result, So we're able to know whether the estimation of those infants were overestimate or not. So in September, because we need to implement the strategy within the 10 regions in 5 months. And then in September, we will now compare the results according to what we were seeking to. And this result will help us to take some decision making. Now, concerning some difficulty challenges that we had. The first one is the sociocultural barrier. The sociocultural barrier, because in some family, they will refuse or test the children by parents due to stigma, cultural barrier, and also high children or no sibling of English case living at very long distance. The other challenge that we have now is intermittent start out of PCR. So there are some infants that are eligible to PCR. Unfortunately, when they reach to the health facility, the reagent is not available. And the other challenge that we have is the age of testing for adolescents in Cameroon. In Cameroon, to offer tests to an adolescent without consent, we should have informed an emancipated adolescent, somebody who has already delivered or who is already married. So it's very difficult for us to offer testing to an adolescent less than 15 years. That is a big challenge that we have. But in addition to all those challenges, I would also like to share some facilitator with you. So the first facilitator is the community-based intervention supported by UNICEF in 61 health districts in Cameroon within 6 regions. And the other one is the existence of psychosocial support and community health worker at some site enabling outreach testing. Also, the HIV risk screening conducted in community by the OVC program really permit also identification of at-risk persons, including children, and facilitate their access to the health facility. So these are some information that I can share with you on behalf of the Ministry of Public Health in Cameroon. Thank you.
Yeah, thank you, Dr. Alice, and thanks for highlighting the role, like you said, of engaging communities and community-based organizations, and also programs like orphans and vulnerable children programs that can really come and wrap around these services and make it, easier, like you said, providing psychosocial support, transport support, other things that make it easier for families to test their children. And, when we think about index testing, I think often there's an assumption that, these children have already been offered testing, right? Or they already know their HIV status. But what we see time and time again, for example, EGPATH implemented the PACE initiative in DRC and Kenya in 2020. And in DRC, 70% of the people living with HIV, these are people on treatment, had children, a biological child with an unknown HIV status. This is in 2020. And in Kenya, 40% of PLHIV at these sites had a child with an unknown HIV status. And, the BGAP study from Zimbabwe, similarly, it showed, about 39% of biological children had an unknown HIV status. And so when we think about our index testing programs, it's not just testing the children or offering testing to children of people who are newly diagnosed, but this is really people who may have been on treatment for years when our PMTCT programs weren't quite as strong yet. And, the average age, one of the things this brief highlights is that average age at diagnosis is around, 8, 9, 10 years old. And so, you know, as we're thinking, we really do want to test these children early. And you mentioned early infant diagnosis, and it's so critical because we know the mortality is so high. But for those children who do live, they often go many years kind of under the radar. And so, you know, thanks for highlighting the ways that we can better engage, you know, community through these different programs. And I think really nice to hear at the beginning too, from the father and just the important role that fathers play in testing their children. We had supported two studies around assisted or caregiver assisted HIV testing in Uganda and Zambia. And 25% of the caregivers were fathers. And the fathers, when we looked at the average number of children they brought for testing, the fathers average just slightly higher, like one more child, you know, so just really when we're engaging the whole family, you know, how that really helps in terms of engaging the kids in these testing services. So thank you, Dr. Alice, for sharing Cameroon's experience. And at this point, we're going to turn to Dr. Nandita Sugandi, who's a pediatric consultant with the Global HIV, Hepatitis, and STI programs at WHO. Dr. Nandita, thank you so much for joining us today.
Okay, thank you.
Jessica.
So for many years, there was a focus on early infant diagnosis, or EID, for pediatric case finding. And, you know, as we mentioned, these programs are very critical given the high mortality for children living with HIV during the first 2 years of life. You know, however, as we get more and more data on the epidemiology of children living with HIV, there's a recognition that to close the treatment gap, pediatric HIV programs will need to test children beyond 2 years of age. And so we're curious to hear what have been some of the policy and guideline changes that have helped countries move forward with pediatric HIV testing.
Great. Thanks for that question, Jessica. And I want to start out by just clarifying, when we're talking about early infant diagnosis or infant diagnosis, we're talking about sort of routine testing using PCR. And the reason we are using that is because the rapid tests that, or even the self-tests that depend on antibodies, can't differentiate between maternal antibodies that infants may have, you know, after delivery, or the infant's own antibodies. And so that's why we need really a virologic test to determine status. And when we talk about the EID sort of or infant testing cascade, we're talking about testing in a routine care setting. So we usually think about EID for the infants of mothers that have come through a PMTCT program or known to be positive. But we also have known for a long time that we're not finding all those women, or we're not finding all those exposed infants in that period. And so I want to differentiate between what is sort of considered routine testing, so that we know we can rule out and confirm that infection has been ruled out at the end of breastfeeding, versus testing that's sort of risk-based or initiated because there's a concern about pediatric HIV testing. And I think those are two very separate issues. And so I want to make sure that, and again, I'm stressing this because I do think there's a need to strengthen the infant diagnosis pathway and make sure that all infants born to women living with HIV are fully screened and have regular infant testing until the end of the exposure period to make sure they are negative. But again, we still need case finding for all of those infants that have slipped through the cracks of routine care. And it's still very important to remember that antibody tests can be used in children from 2 and onwards, but below that, we still really need to confirm with virologic testing. But in terms of what WHO has been doing and what sort of policies has helped, I think talking about the tests that we need and the tests that we use is really critical. So WHO, while WHO does not have a specific recommendation around using self-tests for testing children in the context of sort of caregiver assisted testing, it's not because those tests cannot be used, it's because there's not enough evidence to form a full recommendation. And so again, I think these programs and some of these initiatives are really helping to drive some of that evidence building that's really needed to make a firm recommendation. But a few other things that have been done, I will say that we've launched the triple elimination agenda. So that's for the elimination of not just vertical transmission of HIV, but also for syphilis and hepatitis C and B. And so those are all opportunities to still kind of link into the routine care network, whether for mothers who are at high risk and they may not test positive for HIV during ANC, but if they test for syphilis, we may have more of an idea of risk factors and so forth. So I think some of this work around the triple elimination agenda can bring focus to sort of the issues around EMTCT and elimination of new transmissions. I think another huge change has actually been in the introduction of dolutegravir and the changes that we've had over the years to introduce new treatment. And one of the reasons why we hear caregivers may be reluctant to test their children is because they are afraid of HIV to this day, that they still feel it's a death sentence. They still feel like that is, that they, there are some, there's a lot of trauma in remembering how people have lived and suffered in the past from HIV. And I think it's also important to remind caregivers that there's very effective treatment. There are children who have grown, have lived healthy lives, who are parents themselves now. And we can do that because of the treatment we have. And so I think, again, this is not just looking at a specific point in time or one specific intervention, but I do think we have to think about sort of the life course and the cascade of care and really think about tailoring our interventions to fit the needs of people where they are. And then the last thing that I really want to bring up is when we think about the policies that we need, we think a lot about age of consent as the policy for adolescent testing. And I think that age of consent is important in terms of policy, but we also have to think about some other policies outside of the health sector. So that includes laws that criminalize certain behaviors or laws that criminalize HIV transmission, because I think those are all factors that really impact how readily caregivers feel sort of bringing their children forward. So those are just a few comments from my end, and I'm happy to look at the questions or take any other questions. Thank you.
Yeah, thank you so much, Nandita. And, like you said, that policy environment around making sure caregivers feel comfortable and even the messaging that our programs are giving, right, to help people understand the current treatment that we have and that children can really live healthy lives and thrive, changing some of the mindset and the messaging, from fear to the optimism that's there. I know in the WHO guidance, like a lot of the recommendations focus on using a mix of different testing strategies. Really, for HIV testing for children, there's not one silver bullet approach, but we really need to be looking for children in all these different ways. And so with that, we'll pivot to Dr. Hillary Wolf. She is the lead for the HIV care and treatment team with PEPFAR at GHSD. Hillary, thank you so much for taking the time to join the panel today. So given the historic under-testing among children and the declines in pediatric HIV testing with some of the programmatic shifts and also the COVID pandemic in 2019 and 2020, we're curious to hear from you on the donor side, the role of donors in terms of strategy and also resource allocation to expand and target pediatric HIV testing.
Thanks so much, Jessica, and good morning, good afternoon, everyone. Great to be here with all of you and great to see all of the wonderful questions and engagement. I think it's just a testament to how much this is really needed at this time. So yeah, in terms of just sort of broader donor considerations, I think donors really are obligated to coordinate across themselves and ensure that we have a collective strategy and resources allocation to align with country priorities. Secondly, I think the obligation for donors is really to bring our technical expertise that is needed to help countries make evidence-based informed decisions for national policies. And lastly, just from a broad perspective, it's really also donors' responsibility to mobilize the commitment to truly end pediatric HIV infections and ensure linkage to treatment for all children already living with HIV. And while it is imperative that we reach our 2030 goals, there's much that really can be done in the coming year. Just to give some examples, from PEPFAR specifically, PEPFAR is not working in isolation. We are tightly linked with other donors, players, as well as partner countries. We also have to balance the need to ensure that program decisions are country-led while recognizing the need for dedicated resources for pediatric HIV testing programs, given the glaring gaps. I do think we should be optimistic that there has been an improvement on how countries are prioritizing equity populations, such as children, based on PEPFAR's 5-year strategy that includes Pillar 1, which really focuses on equity. And we'd be remiss to not mention the political will that has come out of the Global Alliance and other initiatives and surges. So just as an example, looking at the preliminary PEPFAR country operational plan budgets for the upcoming fiscal year, we see that about half of our countries report a budget increase in children when you look at the coming year versus the prior year. And there was about 5% increase in children beneficiary budgets across all of the COP countries compared to their overall country trajectory budget. So that's good news, recognizing that there will always be countries who are outliers who need to invest more in pediatric programming, and therefore it is important that we delve into the pediatric testing strategies and resource allocation for each country, while taking into consideration the overall budget environment that a country is operating in. I don't think at this point that a general rallying call for more money for children will resonate, but rather a thorough review of a country's program and where there may be gaps across both donors that we can really dig into. As we prioritize sustainability roadmaps, PEPFAR's planning and implementation processes are evolving to create a meaningful alignment with government priorities, processes, and systems to support a greater government role in service delivery and program management. However, we fully recognize that PEPFAR and other donors will need to continue to focus on closing and being accountable to equity gaps, as government systems don't always reflect underlying societal inequities. We hope to outline this vision further in our COP25 guidance that will be released later this year. Lastly, I just want to state that PEPFAR is really committed to prioritizing testing for prevention and treatment for children by casting a wide net to ensure all diagnosed children are tested and linked to treatment, recognizing that the last mile efforts will likely require more resources.
Yeah, thank you for those comments, Hillary. And like you said, for children, if we have to test 15 adults to find one positive adult living with HIV, we have to test about 100 children. So we know with this pediatric population, we already have to test more to kind of find the same. And then, like you said, as we get closer to the 90s, that last mile requires even more testing. And so thanks for highlighting the role of coordination amongst the donor community to ensure that we have adequate resources, to have adequate commodities to test at the volume needed to close these gaps. So let me just close by saying thank you to each of our panelists, from caregivers that joined us today to policymakers, to donors. We really appreciate hearing from each of your perspectives and your experience with the work that you do and in your countries. And at this point, I'm going to hand it over to Shafiq Asaji, and he'll close us out and talk about next steps. Thanks so much.
Thank you very much indeed, Jessica. And thank you to all of you for the time that you've given us today and the attention that you've been paying. We can tell how much interest there is in this area just because of the number of questions that we've received, many of which we haven't had time to fully answer during this past hour and a half, but we will get to all of those answers in due course. In my summing up, I just want to recognize that there's really an emerging sense that this is a critical area that we have to address if we're going to end the inequity in treatment access for children. We saw those very elegant curves from Ruslan that showcase really how big the gap is between adults and children and how it's been getting wider, and also underscore for us the importance of recognizing the value of that first step, that knowledge of diagnosis step, as the first hurdle that we have to cross in order to improve access. There's clearly a lot of areas where we still have questions around self-testing. When is it appropriate? When is it not? Around the risk screening tools, what makes sense? But I think one key message is that this work has to be contextualized. There is no magic bullet or one size fits all. It's really work that needs to evolve as the epidemic evolves. And so a solution for one setting may be very different to a solution that's appropriate for another setting. We've also heard from you the importance of thinking about translating this document for other countries, and we will take that very seriously, and see how we can generate translations for you quickly so that they can start to be used in Lusophone, Francophone, and Spanish-speaking countries. And we also heard from many of you the importance of looking at other age groups, in addition to the younger children that we've been focusing on for this technical brief. What about issues of older children and adolescents? Is there value in pulling together some of our best thinking on strategies and approaches to increase identification in those groups? I want to close by saying this is the beginning of a conversation and not the end of it. The chat that Isabella has just posted in the chat group, which I hope you can all read. I'm not sure if the chat is visible to everybody. Rike, if it isn't, then we'll have to figure out another way of getting this to you. But if you're interested in staying engaged with us, then please click on that link to sign up for an interest group, where we just at this point just need your contact information, so that we can keep you in the loop. And when we form a smaller group as part of the Child Survival Working Group to kind of take some of these ideas forward, we'll have your contact information to keep you in the loop and get you involved with that discussion as it proceeds. So please click on the link, stay tuned for more information, and join us on this journey as we continue to unpack and address the low coverage of testing for children and the work that we can do to improve it. And with that, let me thank you all again. We will send out all of this information, as well as the slides from this discussion, to all the folks that have been on the webinar. So if you can't access the link to join the interest group, please watch out for an email that you should be receiving with that link that you can click on to stay engaged in this conversation. And so with that, thank you all. We look forward to continuing to work on this with you as it evolves.